Men låt oss då börja med det första föredraget som ju då handlar om barn och unga med ME CFS. Det är ju professor Kristian Sommerfelt som kommer att lämna en presentation. Han är från Universitetet i Bergen, barnläkare, och har en lång erfarenhet både av klinik, av forskning och undervisning, och har intresserat sig bland annat då för mycket prematura barn, deras utveckling, men också för barn med ME/CFS, där han har ägnat stor uppmärksamhet framförallt åt deras symptom, men också metabola funktioner, kramptillstånd och annat som är kopplat till det hela. Och då kan vi börja att spela upp professor Sommerfelts presentation.
My name is Kristian Sommerfelt. I'm working as a pediatrician in Bergen, Norway, at the University Hospital, both clinically and in research. So I'm working with pediatric neurology, and I'm a professor of pediatric neurology. I'm going to be talking about pediatric ME, or ME/CFS, which is a newly acquired debilitating disease that can be seen in all age groups. There are two age groups in which it is more common to arise, that is in children and adolescents from 12 to 19 years of age, and in adults 30 to 50 years of age approximately. The hallmark of this disease is newly acquired fatigue that is extensive and is both regarding motor activities like running, moving around, and cognitive social activities like going to school, being with friends, etc. It must have lasted more than 6 months before the disease is considered. There are other symptoms that are very important in diagnosing this disease, and it is very important to recognize that it is based on a set of symptoms. So the criteria used are important. For example, in British studies, a wide definition is used, resulting in many more children or adolescents being diagnosed, maybe 5 times more. We use the Jason 2006 criteria, which are strict. So pediatric ME is like a magnifying glass when trying to understand ME. Why? Well, because children are in a family being observed, they are in school being observed, and school is compulsory. That is, if a child gets ME, then it is not possible to continue previous activities at all. And the teacher knows the child from before, usually, and of course the parents do. So there is a drastic reduction in the capability of the child or adolescent person to continue daily activities. So when a child has these symptoms, they go to the doctor, and the doctor would look for causes, and probably not finding a cause, then referring the child or adolescent to a hospital for further evaluation. And when that happens, the first task of the doctor at the hospital, the pediatrician in this case, is to rule out, as far as possible, other causes of the symptoms. And in this case, that would be, for example, thinking that it could be a brain tumor, which is not a typical set of symptoms for that. Other diseases, thyroid disease, celiac disease, and a range of other diseases. So there is a set of investigations that needs to be done. But when first meeting a child that may have ME, it's extremely important that a strategy is used during the examination. So I have, and probably other people have, developed their own way of doing this. The way I do it is, after greeting shortly, friendly, then I tell the family, which is usually both parents, hopefully, and the child or adolescent, then I ask that only the child answers the questions, and the parents are not allowed to say one single word until I'm finished with that first phase. Now that is, of course, generally a good approach, often with young people, children, because you want to hear their description of the symptoms. But there's another reason too, and that's very important, which is caused by a very common or always present symptom in ME, namely brain fog. That is that the patient is unable to focus appropriately after a certain amount of time. And that amount of time may be 15 minutes, 30 minutes, 45 minutes, sometimes more. That means that I, as a doctor, want those best minutes for myself so that I can focus on exactly how the symptoms are. Now, another technique that I use to get the child to prioritize the symptoms is to ask this question. If I were a magician and not a doctor, what would you want me to make magically go away first if you could choose only one symptom, only one thing that is making your life difficult now? Now they immediately understand the question, and what they usually give up first is that they are feeling fatigue, or another word for that. And then I ask if that is regarding both motor functions, moving around, and talking, social functions, school, etc. Now, then I say, if we pretend that that symptom is not there anymore, what's the next one you would want me to take away? And that varies a little bit. Typically, it would be pain, headache, stomach ache, sometimes nausea, dizziness. And then I would ask, if that is taken away, what would be the next thing that you would want me to take away? Now, typically, they don't have more than 2 or 3 symptoms like that they want me to take away. Now, that does not conclude my case history with the patient. Then I ask specifically for symptoms that may be typical for ME, and of course I may ask for symptoms that go in another direction if I suspect another disease or symptom set. So typically the first question I would ask after that would be, how is that fatigue? What do you mean fatigue? Are you sleepy and want to go to sleep and feel nice afterwards? And they would say no. They feel like they can't do what they did before. They feel sick. They use different words. So it seems it's a feeling that is similar to having a flu, sick, feeling sick, but also not able to be active, both motor-wise and cognitively, in a normal way. Then I would ask about the hallmark feature of ME, which is exertional intolerance, post-exertional malaise, PEM is the word I'm using from now on. So I would ask, what happens if you do definitely more than you usually do on a day, either because you want to do it or because you have to do it? For example, going to a birthday party or being with quite a few friends in the evening or something else. Then I ask, what would happen the day after, or maybe starting the day after that again? Are you feeling really good because you've done a lot? And they would say, if they have PEM, they would say, no, I feel not good at all. Sometimes I have to stay in bed or rest, feel worse. And then I ask more about that. Maybe they have increased pain, maybe nausea. And then I ask, how long may that last maximum? And they often say 2 days, but they may say a week or longer. Typically 1 day. Then I would ask about another symptom, which is brain fog, cognitive functions. So I would ask them, how long could I continue this conversation, or how long could you be active talking to a friend about something pretty intense, continuously talking? And they would say they don't know. Well, I would ask them how much approximately, like 4 hours or 15 minutes, and they would typically say, no, with 30, 45 minutes. So they actually know when their normal capacity for talking is reduced. Then I would ask them, are you sometimes using the wrong word for something, like, can you pass me the car? And they mean the milk. And then I would ask if they have a problem finding words, or if their memory has been less good lately. Next topic would be pain, if they have any pains, for example, headache. And I would ask about characteristics of the headache, whether it's there all the time, some of the time, what makes it worse? Does it increase if they are more active, which is typical? I would ask about muscle pains, for example, in the overarms or in the thighs or in joints, or stomach ache, which are typical areas of pain that you may have in ME. Another area is symptoms that are probably connected with the autonomic nervous system, the nervous system that we don't have to consciously think about. And I would ask them if they feel inadequately or strangely warm or cold sometimes. And they may say yes to that. Another problem they may have is that they may feel unwell if they have been standing for a long time, which is orthostatic intolerance. Not dizzy when they rise quickly, which is very common normally, but after having stood up for quite some time, if that feels bad. Taking a shower, is that a problem, or is it nice to take a warm shower? And often they say they feel very bad taking a warm shower. During the shower and afterwards, often. Not necessarily, but it's a common symptom. Sleep is another area where they may have problems, for example, falling asleep or having much more sleep than they usually had before this all started. Maybe going from 8 to 12 hours, that may happen. So sometimes they lie awake for a couple of hours before they fall asleep. And when they awake, do you feel refreshed as you did before? And they may typically say almost always no, that they don't feel rested after sleep. Some patients may have nausea or dizziness. Nausea may be really bad. It may not be there at all as a symptom. Having sensitivity, hypersensitivity to noises, sound, or light is also very common. Another thing is increased pulse, which they may feel, or may be found by the parents if they test it. May not be there, but it's not very rare. Something that is not written much about, but I have been interested in it, that is that quite a few of these patients with typical ME have myoclonic jerks. Not common, and it's not a problem, but it's just a short jerking of the hand, usually on one side, maybe once a week, twice a week, but it wasn't there before. So regarding the symptoms, the patient would be the reliable source. They may often not tell their parents about symptoms that they may have almost all the time, like headache. On the other hand, regarding capacity, what they are able to go through with of activities, the parents are usually a much more reliable source because the patient tends to forget what really has been done, for example, in school participation, seeing friends, etc. And also, it's probably the case that the patient paints a more positive picture of his or her reality than what is really the case. Listening to what patients with ME are able to do, it's striking that activities that at any time can be paused, put on hold, are much easier to participate in. Now, video gaming is something that especially boys with ME do quite a lot if they're not able to do much else. One would think that that is very exhausting. It is not, because they can take pauses and they can do it on autopilot, so to say. So one cannot judge the amount of time they use on that as time that could be spent in school. So if the patient satisfies the criteria of Jason 2006 and no other cause has been found for the disorder, then the diagnosis is given. But this means that you have done a set of investigations, including in Norway, we have agreed on MR of the brain, magnetic resonance imaging of the brain, ultrasound of abdomen and X-ray of the chest, and a large set of blood evaluations to diagnose or try to exclude other possible causes. For example, hypothyreosis, celiac disorder, and a lot of others. In Norway, when we do the evaluations at the beginning before diagnosis, child psychiatric evaluation is done to see if something completely else is the problem, or to diagnose possible comorbidities such as learning difficulties, etc. Now, such things would not be the cause of ME, but maybe, of course, important to diagnose and to handle in an appropriate way. If the diagnosis is given, then our next step is to have a meeting, transferring knowledge of this to school, general practitioner, family, and other health workers that may be important around the child or adolescent person. This is very important, and it is done at the same time, either through video consultation for some of the persons or being together in the same room. So everybody has heard the same explanation of symptoms and how to help the person, how to tackle the situation, both for the patient, the family, and the school, and the general practitioner. Advice. There are some treatments that can be very effective, for example, for sleep problems. Insomnia, problems falling asleep. Melatonin may be very helpful, 3 milligrams, maybe 6 milligrams, maybe 9 milligrams. So I would very often prescribe that. Mental health in pediatric ME is typically good. They don't have depression or anxiety as a part of this syndrome at all. It may occur much later if the disease persists over many years. For example, anxiety, which may be alleviated and helped by competent personnel, psychiatrists, psychologists, etc. But that's a different story. So how common is this disorder? Well, there are not enough good studies at all, but approximately 0.5 to 0.8 of the population have ME, probably. And how reduced is their capacity for participating in life? Well, typically when pediatric ME is diagnosed, their capacity is roughly estimated 10 to 20% of what their capacity was before. In other words, they are not able to attend school normally, do their homework normally at all, maybe not attending school at all, and activities apart from school, like being with friends or physical activities, football, may have been stopped altogether or reduced drastically. But there are all degrees of the disorder, even to the very severe who are bedbound, not able to eat possibly, and that's very few but very important small subgroup. So has this been a constant disorder, talking about prevalence? Well, it doesn't seem that way. I have been working at the same position in Western Norway from the beginning of the 90s, and we saw 0 to 2 per year. Some may have been undiagnosed and not referred, but school is compulsory, and we had every child in a population of 500,000. So below 15 years of age, 0 to 2 per year for many, many years. And then in 2006, 2009, suddenly it rose to 15 to 20, 25 per year. And it is at that level still. And that has been described in other parts of the world where it seems to be slow epidemics of this disease or a very similar disease. In Iceland, in upstate New York, etc. Female preponderance is very common in adults. It's not so obvious in the pediatric population, but somewhat more female. 20% have another first-degree relative with ME, which is striking. And there is probably a doubled frequency of various autoimmune disorders in the family. 80% of cases with an established diagnosis of ME have an infection in the case history at the beginning. So, of course, this is diagnosed retrospectively, but typical symptoms, usually of a viral nature, at the beginning of the disease, then progressive symptoms until definite symptoms are there. There is no association with personality type, psychosocial trauma at the beginning, or accompanied other disorders such as learning disabilities, attention deficit disorders, etc. It seems to be able to strike anybody. Also, there is no support for parents' handling of the disease as sustaining the disease. This has been hypothesized, and it has not been supported. A biopsychosocial hypothesis is often put forward. That may be the case in any chronic disease, that you have to look at biological factors, psychological factors in the specific patients, and social factors, those around. But there seems to be no indication that this is more applicable to ME than to other chronic diseases such as diabetes or rheumatoid arthritis, etc. There has been no breakthrough regarding the cause of this disorder. Sadly, it does not seem to be a psychosomatic disorder. That would have been a really great news. It does not seem to be the case. Research and findings definitely go in a biological direction, which is, of course, very important if that is the case, because then that may lead us to efficient treatments. The prognosis of pediatric ME is uncertain because so little research has been done. There is one study from last year, Australia, which had deficits in the study design, but was still really giving information. Follow-up time was very different, from 3 to something like 20 years. And it seemed that 50% of those that were contacted, they said that they were well, not having ME anymore, but they had a free text area where they could write, and many of those, they wrote that they don't know what well is. Still, if they put that in, it means that they could lead a very fulfilling life in some way. What would I tell a child, an adolescent, and their families about the prognosis? I would say that the disorder may go away at any time, or may be improved greatly at any time, but usually that does not happen in several years. And we don't know. So never lying, but it's reasonable to be optimistic that recovery or at least improvement is possible. So how do you treat the disorder? Are there effective treatments? And the answer to that is no, we don't have effective treatments. There was hope that cognitive behavioral therapy could be effective treatment, giving results that the person would be well. There is no indication of that in the studies that are available. The only usable approach is doing what they can do, not do what they can't do. Well, that seems pretty obvious in a way, but it needs to be regulated. It needs to be thought about. How do you do this in practice? So pacing is a word used for that. Because they have just 20 liters of gasoline or whatever, and they need to use that in the best way possible. For example, school participation, if that is possible, and as much as possible. But possible means as much as possible without feeling really bad when they are doing it, and not being very unwell the day after, PEM, post-exertional malaise. So this is an example of how ME may hide. They may be in school and really use up their energy because they want to participate, they want to be with their friends, they want to learn. And they may look completely as before on that day if they don't have more severe ME. But the next day, if they have crossed their level, they may be much worse, not going to school at all. But the other pupils and the teachers don't see that. So when they come back to school maybe 2 days later, they look okay again. So if you don't really go into what's happening, the whole disease may pass you by and you may not believe in it at all. And that happens to patients with ME so often. It's a rotten disease because it hides. It's a rat. Why? Well, when you go to the doctor, all the tests are normal. That happens with migraine too, etc. But it's worse than that. When you go to the doctor, you look completely normal and you usually talk completely normally. You don't spot the brain fog because the patient may take an extra amount of that gasoline if they need to at the hospital or with the doctor. So the persons that saw the patient may think, well, looked fine, all tests were normal. They don't see the patient when they have PEM afterwards. Then they're at home. You don't go out when you feel that way. And it's even worse than that. If you ask a young person with ME how they are doing, one of my patients, I ask them, how are you doing now? When they come for a follow-up visit. And they would typically say, I'm fine. Well, they look fine, all tests are normal, and when you ask them, they are fine. So what's the problem? Well, that's an example of autocognitive therapy to me. What they are doing is they are looking at their situation and their life in the best way possible. They're not focusing on symptoms, and they are being tough and enduring this awful disease. And that in itself makes it much less visible. So rule one, when one has to do with ME patients, is to not add to the burden of the disease. The age-old law for doctors, lege non nocere, at least do no harm. And that is violated in so many cases with ME. All the way up to the child protection services coming to take the child away from the family. It happens. Or blaming the parents for the disorder. Munchausen by proxy, for example. So the main thing is to be really listening to the patient and the parents. this has led me to the conclusion that those who really are best in Norway in tackling the disease around the family is schools. They have become really good because sadly it's the most common cause of long-term absence from school when school is compulsory. So they have learned to recognize the disease, and often they have really done the adjustments that are necessary before the diagnosis is given, because they recognize it from previous pupils. Now the next best is general practitioners in Norway. Quite a few of them, very many and increasing numbers, are doing a great job in handling the patients in the best way possible. Now, the specialist services, the hospitals, that is another story. They are very variable in the way they are handling it. Some places it's very good, but usually it's not good because of the invisibility of the disease. In summary, I think that it is a disgrace the way this disease is handled quite often. It's not recognized, and often insult is added to injury, leaving the patient and the families in a very bad situation. This must change.